Good afternoon, everyone, and welcome to today's IFAM webinar. I'm Ron Ackerman, and I direct the Institute for Public Health and Medicine. Before I introduce our presenter for today, I wanted to remind you all again that we encourage any member of the listening audience to submit questions to our presenters at any point during the presentation. To do so, simply click the Q&A button at the bottom of your Zoom screen. At the end of the presentation, as well as midpoint in the presentation, we'll take a pause to answer any questions in the Q&A section. Today, I have the pleasure of introducing Dr. Sara Becker, who is Associate Professor of Behavioral and Social Sciences and Associate Professor of Psychiatry and Human Behavior at Brown University School of Public Health. Dr. Becker is a clinical psychologist and implementation scientist dedicated to bridging the gap between research and practice. Dr. Becker studies both patient-focused dissemination and provider-focused implementation strategies spanning community and clinical settings. Dr. Becker currently is principal investigator for several federally funded dissemination and implementation studies in areas that span a comparative trial of multi-level strategies to implement contingency management services in 30 opioid treatment centers throughout New England, evaluation of using a train-the-trainer strategy to implement screening, brief intervention, and referral to treatment for risky alcohol users in HIV service organizations in South Africa, and a pragmatic trial of a scalable technology-assisted intervention for parents of adolescents in residential treatment. Dr. Becker also is principal investigator of the New England Addiction Technology Transfer Center, a SAMHSA-funded center which provides training and technical assistance to over 2,100 frontline addiction treatment providers per year. Dr. Becker's presentation today is titled, Promoting the Uptake of Effective Treatment via Dissemination and Implementation Science. Sara, we're delighted to have you with us today, and I'll turn the microphone to you.
Thank you so much for that wonderful and warm welcome. I'm absolutely thrilled to be here today and to be invited to speak as part of the IFAM seminar series. I'm especially delighted because I get the chance to speak about one of my favorite topics, which is promoting the uptake of effective treatment via dissemination and implementation science. I had a slight delay when I was listening to Ron before, so if at any point I am delayed, I hope someone will unmute and tell me that so that I can turn my camera off, just in case, because I'm using a lot of animation today and we just want to make sure that all of that is visible without freezing. So I
think it was me, Sara, so I think you're fine.
Okay, all right, wonderful. Yeah. Okay, great. So as Ron mentioned, I am an associate professor currently at the Brown University School of Public Health, where as one of my many roles, I direct a regional training center. So I spend a lot of time on Zoom, either coordinating or directing or leading virtual trainings. And I like to acknowledge that there's a level of spontaneity that occurs when we're in person together that's a little bit challenging to replicate in a virtual format. If we were together, I could see if you're nodding and enthusiastically smiling and engaged in the conversation, or I could see if brows were furrowed and heads were tilted, and I would modulate accordingly. Since I won't have any visual cues today, what I'd ask is that you please do feel free to use the chat for comments or reactions, and that you use the Q&A at any time for questions. And I'll actually pause about halfway through today just to try to roll up things that have come through until that point, just to have a little bit more interactivity and to encourage people to actually engage in the content. So without further ado, I'd like to start with an attitude of gratitude. And I'd like to acknowledge the various funders that made this work possible. I'm going to be sharing a lot of different examples throughout today's talk, and none of this would be possible without the funding agency, so I want to thank them. I also specifically want to thank a few individuals. To our faculty from the Training Institute of Dissemination and Implementation Research in Health. I was very fortunate to be part of the inaugural cohort in 2011. And two of the faculty there, Drs. Enola Proctor and Larry Green, shared some of their seminal dissemination and implementation slides. And I'm using two in particular as part of my background today, so I want to thank them for their generosity. I also want to thank sincerely my colleague and friend, Dr. Brian Garner, because I'm going to be talking about one project that we co-lead together, and some of the wonderful visual graphics are ones that he created. So I want to thank him both for being a scientific partner and friend, and also for really elevating the visual quality of the slides. So here's what I hope to do in our about 50 minutes or so together. I hope to first provide a brief overview of the what, why, and how of dissemination and implementation science. And my goal here is to really give us shared terms and concepts so that we have a foundation for the rest of the talk that we'll be doing together. Second, I'd like to spend most of the time taking a deep dive into case examples. I'll give you one detailed case example of an active implementation science project, and then one detailed case example, but much shorter in scope, of a dissemination science project that was recently completed. And then I'm going to give you several bonus, really quick examples of ongoing dissemination and implementation science projects being done by my team, just to give you a sense of the breadth of implementation science designs, measures, contextual determinants, and strategies that you can use in this space. And then finally, I'd like to conclude with some reflections and tips about where I think the field is headed and some of the areas that I'm really excited to be pursuing with my team in our future work. Without further ado, let's jump into section 1, which is the what, why, and how of dissemination and implementation science, or D&I science for short. When I talk about D&I science, I'm generally referring to strategies that are intentional and proactive, designed to build the space between public health and medical knowledge, or what we know, and public health and medical practice, or what we do. Specifically, when I use these terms, I tend to adopt the terms put forward by the National Institutes of Health. And I'm not going to read these to you, but what I want to emphasize is that dissemination science research and implementation science research are not the same, but are really complementary and fundamentally linked. We can think of dissemination research as the act of targeted distribution of information, typically with the goal of building knowledge and awareness of a specific public health intervention or innovation. Implementation research, on the other hand, is the use of specific strategies to integrate a specific innovation into a specific setting. In a former life, I was a double major in psychology and economics, and I worked in business for several years. So when I put my economics hat on, I like to think of dissemination research as research designed to increase consumer demand for effective treatments or innovations, and implementation research as research designed to increase the supply of those innovations in community and clinical contexts. And I think we can hopefully all agree that we really need to do both of those things. If you think about vaccine rollout in this country, I would argue that we did a fabulous job with the supply. We got shots out to different communities. They were available in community settings. Where we really struggled was with demand. We had a hard time getting shots in arms because we weren't thinking about messaging of how to get people to actually demand the services. So really both of these things are two sides of the same coin that need to be done concurrently. So why do we need D&I science? I like to answer this question with a visual metaphor of the healthcare system in the United States. And what you're seeing is actually a picture of the Grand Canyon that I took on a vacation about 15 years ago. And the reason I like this as a visual metaphor is that you're looking at one enormous canyon, but it's comprised of multiple gaps that are adjacent, overlapping, and intersecting to form this enormous challenge. And I think that's really an apt metaphor. When we think about the healthcare system, there's not one singular problem we're trying to address. We're trying to address problems at multiple levels, in multiple settings, multiple complex intersecting issues that together form an enormous challenge. When we talk about gaps, we typically focus on one, and I want to argue that there's two gaps that we really need to be thinking about when talking about this space. The first gap is the one that you're probably all most familiar with. This is what we typically call the research to practice gap, the evidence to practice gap. In lay terms, this is the gap between the care that could be, if we really worked and did what we know, versus the care that actually is available, or in terms of what we do. I don't think I need to convince you that this is an issue, but if I did, there's 3 landmark reports from the Institute of Medicine dating from the late 90s to the early 2000s, where they do a really beautiful job documenting just the enormity of this challenge. And what I love is they don't call it a gap, they actually call it a quality chasm, just to give you a sense of the scope of the problem. I do a lot of my content research in the addiction field. There's a beautiful landmark paper by McClellan and Myers in 2004 that surveyed the addiction treatment system and just documented all of the gaps and challenges at multiple levels. They were documenting administrative gaps, personnel gaps, funding gaps, policy gaps, all that make it very difficult to bridge research to practice. And then finally, there was a recent Surgeon General's report that presented a pretty bleak overview of the addiction treatment system. And without getting into too much detail, there's a number of unique challenges when you work in addiction. There's the stigma that is faced by persons with substance use disorders, the stigma towards the treatment themselves. There's a long historical reliance on folk wisdom within the field. And there's also really inequitable reimbursement of services. So all of those kind of create a perfect storm that make addiction somewhat unique when relative to other mental health and physical health issues. Now, there's a second gap that I've been very intentional about trying to address in my team's work and also have been actively presenting and publishing on for the last decade. And that's really the gap between those who need treatment and those who receive any treatment at all. We can think of this as the treatment gap or the unmet need gap. In the space where I work, we are blessed with beautiful data of the percent of people with substance use disorders. So what you're seeing now is an annual survey that's done by the Substance Abuse and Mental Health Services Administration, where they survey a representative sample of the US population, and they're able to see what percent of people have a substance use disorder and what percent receive any treatment at all. What we see is really bleak. We see that fewer than 10% of teens and young adults that meet full diagnostic criteria for a disorder receive any specialty treatment. And we see that 13% of adults over the age of 26 who need treatment for a diagnosis receive any at all. The survey, if you actually look at populations, presents an even more bleak view. These gaps are even bigger among those identifying as racial and ethnic minority groups and those of lower socioeconomic status. But beautifully, something that is awesome about these data is it takes it a step further and it asks people, if you didn't get treatment, why not? And we can actually see the primary three reasons are, I wasn't ready to stop using, I didn't think treatment was needed, and I didn't know how to get help. So these reasons are really convincing that simply increasing the supply of treatment out in the community is not sufficient. We also need to be thinking about strategies to increase knowledge, increase awareness, and the increase in consumer demand. So how do we do this? Well, here's the slide from Enola Proctor that I think challenges us to think about how we start to move into the dissemination and implementation science space by starting by thinking about the status quo. So the status quo, we typically think about quality improvement initiatives, empirically supported treatments, other evidence-based practices. Those are kind of interchangeable words. And we look at their effect on patient outcomes like symptoms and functioning. But what that does is ignore a host of contextual issues. For instance, it ignores the how of what strategies did we use to actually get those specific practices into a specific setting. It ignores a host of important outcomes, like was it feasible? Was it acceptable? What was the cost? Could people do it with fidelity? And it ignores a host of service outcomes, like was it efficient? Was it equitable? And was it timely? All of those issues are really at the core of D&I research. And so I want to conclude this background section with just one of my favorite comments, which was shared by Larry Green. And this is a commentary on the status quo. We have some friends up in a hot air balloon, and then we have a friend on the ground. And the friend on the ground is asked a question. The folks in the hot air balloon say, where am I? And the person on the ground says, well, you're 30 meters above the ground in a balloon. And those in the hot air balloon say, oh, you must be a researcher. And they reply, yes, how did you know? And the friends say, because what you told me is absolutely right, but completely unhelpful. And I love this comic because I think when we are doing D&I research, our goal is not to prioritize internal validity and be focusing solely on being right and accurate. Our goal is to really be focusing on being helpful, being relevant, and being contextually fitting. And so we are really flipping things on their head. Of course, we try to still maintain internal validity in our studies, but the goal is not to just be right. The goal is to be helpful. And so I would argue that if you are really centering the views of stakeholders in your research, if you are thinking about making things that are contextually relevant, even if you don't identify as a D&I scientist, you are probably leaning into the principles of D&I science. So now we get to have some fun and we get to take a jump into some case examples. And I'm going to start with an implementation science example of a study called Project Mimic. Mimic stands for Maximizing the Implementation of Motivational Incentives in Clinics. And this is a 5-year R01 that is an MPI project with my friend Brian Garner. And this is funded by the National Institute on Drug Abuse. And just to give you a sense of why we're doing this study, Basically, before the COVID pandemic, I'm sure that many of you were aware that our country was in the midst of another epidemic, and that was the overdose epidemic, primarily driven by opioids, but also in combination with poisoning of the supply and other stimulants and other issues. But what we were seeing was 1.6 million people in the United States meeting full criteria for an opioid use disorder in 2020, and 137 people dying every day from an overdose. Many of you may have seen that there were actually headlines in May that for the first time in US history, we reached a very auspicious milestone where we had 100,000 Americans lose their lives due to overdose in a single year. So it's a very bleak state of affairs. That said, there is some encouraging news. Recovery is possible and evidence-based practices exist. The frontline, most supported interventions for persons with opioid use disorders are medications like methadone and buprenorphine, but the reality is that the outcomes are often suboptimal. That is not to say they're not fantastic, it's just to say that we often need more tools in our toolkit. When we look at patients receiving medication, only 50 to 63% stay engaged with treatment and about 60% relapse. This is in large part because the adherence requirements are very high for methadone and buprenorphine. There's a lot of regulatory stigma where patients are required to come in at a very high frequency, often even daily. And so we could get into a long conversation about regulatory stigma. But basically, because of the issues with adherence, the National Institute on Drug Abuse in their most recent strategic plan, which was 2016 to 2020, really advocated that research focus on pharmacological treatment combined with or augmented with behavioral interventions. And when we look to that literature, it is very clear that there's one behavioral intervention that continually bubbles up as one of the most, if not the most effective. And that's a treatment called contingency management, where patients can earn incentives for meeting their treatment goals. It is arguably the most effective treatment, especially when focused on retention and adherence. It's been studied in hundreds of clinical trials, multiple meta-analyses. We know it works. Yet when you survey the US addiction treatment landscape, and this has been done, when you survey it, it is the least available behavioral treatment. People are more likely to respond to the survey and say that they yell at their patients than they are to say that they deliver contingency management. This is such a problem that the New York Times did a whole piece about this in the fall of 2020 called "This Addiction Treatment is Highly Effective, so why is it not utilized?" And so it's such a challenge that that's why we developed Project Mimic. We saw this seems to be one of the biggest challenges in the addiction field. We know this treatment works, yet patients can't get it. It's not available anywhere. Can we actually work with opioid treatment programs to see if they can integrate it into their usual care? So now I'm showing a visual depiction of our trial design. This is inspired by Enola Proctor's 2009 conceptual model for implementation research, where she encourages researchers to think through some of the specific elements of their study. This beautiful pipeline and visual was developed by Brian Garner. And I just want to highlight, if you look at the left, we have a research pipeline here. If you think about the movement from efficacy research to effectiveness to implementation research, there's a type of design in between effectiveness and implementation research called a hybrid trial. And that's why we have yellow and blue make green. Hybrid trials get numbers, 1, 2, or 3. Lower numbers indicate a leaning towards effectiveness. Higher numbers indicate a leaning towards implementation. This is what's called a hybrid type 3 effectiveness implementation trial. And that's because we know contingency management works. What we don't know is how to implement it. So we are focusing in this trial as our primary outcomes on how to implement contingency management, and we look at patient outcomes as secondary. I'm going to actually walk you through every part of this trial design in the coming slides. So let's start with our intervention. As I mentioned, we are using contingency management. There are different types and models of contingency management. We are using a low-cost model called the fishbowl. If you look at our study logo in the top right of your screen, we have a funky O. That's actually a picture of a fishbowl. The fishbowl method is one where patients actually get draws from the bowl, and they earn prizes of different magnitudes, and sometimes they earn positive reinforcement. The average cost of a draw for an agency is $2. It's a very cost-effective approach. Patients can earn more draws the better they do in treatment. As I believe any good implementation scientist should, we started this project by actually talking to opioid treatment program staff. We applied for funding and were awarded as part of a P20 grant. We were a project component, and we did qualitative research with 11 opioid treatment programs throughout Rhode Island. We basically asked them, if we were to do contingency management in your setting, how would it be designed most effectively? How could we adapt it? What would you want to target? And we heard very clearly that they wanted to target attendance and engagement, but they wanted to have organization-specific and flexible definitions that could vary by organization. So they didn't want every organization to have to do the same thing. And we also heard about the central importance of involving leaders in the implementation project. Moving on to our implementation strategies. This study evaluates 2 multi-level and theoretically driven strategies, and I'm going to talk about each of those in turn. The first one is the ATTC strategy. And the reason for that is because I direct the New England ATTC. It is a regional training center, part of a national network of SAMHSA-funded centers. Our mandate is to basically equip the addiction treatment and recovery workforce by training them in evidence-based practices. And so we have a training strategy that is multi-level. And so we thought that would make a fabulous real-world credible control. And I'm going to talk to you a little bit about the elements of that strategy. The strategy was actually developed before I joined the ATTC. I've been part of the team since 2012. And as early as 2008, the team was writing about a strategy called the Science to Service Laboratory, which was a multi-level strategy to promote organizational change. I've taken it forward and really documented it in multiple works and have been empirically testing it a lot over the last decade. But basically, I would argue that it consists of 3 core elements. The first is didactic training. The second is performance feedback or fidelity monitoring, and the third is ongoing consultation. A lot of times when I hear about implementation strategies, it sounds vague to me or it's hard for me to picture. So I'm actually going to show you these elements in pictures. So here's what a didactic training workshop looks like. This study started pre-COVID. One thing to note about the study is we use a staggered cohort design. So rather than train 30 opioid treatment programs at once, we do 8 to 12 at a time. And with a total of 3 cohorts. So here's our pre-COVID cohort. As you can see, lots of experiential, interactive learning. We are demonstrating what it looks like to draw from the fishbowl. We then have people pair up and practice. We give rewards, lots of cheering. People are engaged. Our second cohort was in a during COVID world. And so we tried to maintain that level of interactivity and experiential learning. You can see the woman in the middle has like her fake fishbowl. She brought an ashtray. We're doing draws, showing everybody's cheering. As a side note, we're actually doing an analysis right now of the effectiveness and cost effectiveness for a special issue journal that's due on the 15th. And our data looks like the virtual training was just as effective as the in-person training, but more cost effective, which clearly has implications for how we continue to train in the future. The second element is fidelity monitoring or performance feedback. We are very fortunate that the prize-based contingency management model, there is a validated fidelity tool. It's called the Contingency Management Competence Scale. And we give people feedback at multiple points. So after training, we have them do a role play using a variety of structured case examples. We let them choose from a menu of case examples. We then give them structured feedback and we require that they hit a readiness benchmark to be cleared to see patients. We then offer them feedback on a monthly basis if they choose, completely optional, but if they choose to send us an audio recording of them delivering contingency management in their usual practice, we will rate it and give them feedback. We also, every single time they deliver contingency management, we ask them to do a self-fidelity check using these items integrated into an electronic tracking platform that is part of their usual care. And then our final element is we do ongoing coaching. We have one coaching call a month that all the sites can come together to share lessons learned. What you see on the left is in a pre-COVID world, we're all there smiling without masks and I'm close to everybody. In a post or during COVID world, I'm the one taking the pictures and I'm socially distanced and everyone's wearing masks, but we still provided the same level of scaffolding in both scenarios. So all of that sounds pretty great, right? So why mess with a good thing? Why not just roll out the ATTC strategy and put a line in the sand that we think that's our ultimate strategy? Well, part of it comes from some piloting work that we did with 18 opioid treatment programs. We had 7 in New England and 11 outside of New England. And basically those in our region got our regional best strategy, which at the time we called the Science to Service Laboratory. Now I'm calling ATTC. And those outside of our region got a didactic training workshop. So just that first element. Notably, the workshop was led by the developer of contingency management. It was truly exceptional as workshops go, but basically we wanted to see, does our multi-level strategy help? And what we saw was whoppingly effective. And we saw much higher odds of delivering contingency management. The blue line is the percent of people adopting contingency management over time if they received our multi-level strategy versus the percent adopting who just received didactic training. But if you're like me, and you have perfectionistic eyes, you will notice areas for improvement. So my eyes immediately go to the places that I think could be better. And those are the beginning and the end. So what's on the bottom are intervals in 4-week intervals. So it took about 5 months for us to really separate from the didactic training and have a higher effect. And as someone that works in the community, really often 5 months is a long time. So I was really concerned about, how could we accelerate the uptake of this and show effects earlier? And then we also saw a voltage drop. We also saw a voltage drop near the end. And so we thought a lot about how could we sustain this better? So that's where we thought maybe we could beat our ATTC strategy with a focus on acceleration and a focus on sustainment. So that's where our enhanced ATTC strategy comes in. And just to give you a logic model, our ATTC strategy is focusing on knowledge and skill to improve consistency and quality, to improve contingency management delivery, and improve opioid outcomes. Our enhanced strategy really builds on the work of my MPI, Brian Garner. I'm really the leader of the ATTC strategy. He's the leader of the enhanced strategy. And basically the focus of the implementation, sustainment, facilitation, which we've layered in, is all about improving the implementation climate to make contingency management more expected, supported, and rewarded, with the hope that that will then improve consistency and quality of delivery and will improve both speed and sustainment. We also layered in incentives because it's been really convincingly shown that if you want to accelerate something, incentivizing staff to do something is one really effective approach. So layered into our ISF strategy, we give providers the opportunity to earn very modest incentives, $50 for every recording that they submit that shows really advanced proficiency, and $200 for every patient that gets 10 CM sessions. I don't have time to go into the enhanced strategy in any more detail, but I believe Brian might be attending today. But either way, if he's here, he can put in the chat some links to our ISF materials, all of which are publicly available on the RTI website. And also our protocol also details all of the incentives in great detail, and the protocol is out in the public space, and I'm happy to share that as well. Okay, so moving on, our aim is to focus on implementation outcomes. We want to see, can we deliver contingency management consistently with quality and in an enduring way? And also we look at client outcomes of abstinence and attendance. This study also has a mediational hypothesis, which I would argue is something we don't do enough in dissemination and implementation science. We specifically say upfront that we believe our enhanced strategy targets implementation climate. We also intentionally engage leaders, so we expect it to improve leadership engagement, and we believe that that will drive any effects on implementation outcomes, and we will explicitly test that here too. So this study is a work in progress. For the next few minutes, I'm just going to very quickly show you some of the types of measures that we're looking at, some of the signals we're seeing. I don't want to give you the sense that we're mining the data. The study is ongoing. So I don't want us to make strong conclusions yet about any of the outcomes, but just to give you a sense of the types of outcomes you can be thinking about in your own work. So one of the things we do in this study, in addition to the framework I've shown you, is we use a phasic approach. So we basically use Greg Aaron's EPIS model to think about outcomes over different phases. EPIS stands for exploration, preparation, implementation, sustainment, and there are specific things we look at in each phase. Exploration was all that qualitative work I told you about before, and in this phase, we're also just looking at, can we engage programs? And basically, yes, we've engaged 18 programs in a phase of exploration. In preparation, one of the things we want to look at is, can we get people to engage in training? And already we're seeing a signal that those in our enhanced condition that get that one extra call a month, we have slightly higher percentage that are actually completing their training. So 85 versus 98. So a signal that something might be happening there. In our implementation phase, one of the things we do is we ask sites to recruit 25 patients per site. We're seeing a signal that those in our enhanced condition are recruiting at higher rates. We're also asking them to track how many patients can reach our exposure benchmark of 10 contingency management sessions. We're seeing that the rates of patients getting that benchmark across condition are very similar, but we're seeing more providers actually getting their patients to that point. So it seems like at the provider level, there's a signal that something's happening. We also look at what % of staff are meeting our skills benchmark, and we're again seeing some signals that the rates are higher in our enhanced condition. And then finally, sustainment. This is something that's really ongoing. We're actually about to launch into sustainment interviews in our second cohort. But what we see is if you look at pure CM, we see 3 of our ATTC sites and 4 of our enhanced sites actively continuing to sustain contingency management, which is exciting since this project was walloped by COVID. What's in parentheses are those that are still doing incentives. I would say they're not really doing contingency management with fidelity, but we are seeing that they are integrating incentives into their usual practice. And we're seeing 6 in ATTC versus 5 in EATTC. Without going into detail, I want to just share that we have an article out right now that we're really proud of, where we looked at sustainment in great detail via qualitative interviews. And because I don't think it's nice to send journal articles to your community partners, my very talented research assistant, Sharon Lang, who's on the call today, created an infographic that we distributed to our community partners. I'm not going to go into this in much depth, but I just want to emphasize that we really explored with folks barriers to them delivering contingency management during COVID. And I think that that has majorly helped us to improve our delivery in our second and third cohort. We heard great suggestions from the programs of adjustments that we could make to our training, adjustments that we could make to our resources that would help them to deliver and sustain in really a telehealth world. And so that has dramatically improved, I think, our resource provision over time in the later cohorts. So some implications before we go on to the next example. So on the left, you see a comic that says, yes, we do have high turnover. In fact, Mr. Hopkins here will finish your interview while I clean out my desk. I love this comic, and man, has turnover been a challenge in this study. We had a detailed 1/3 page staff turnover plan in our grant, where we said we expected 1 in 5 leaders to turn over and 1 in 3 staff. We actually had over 40% of staff turnover in our first 6 months of the project. So what I would argue is if you're doing community engaged research, you need a detailed staff turnover plan. You need a way to have resources available and a way to onboard staff in an ongoing manner that doesn't require a lot of resources. And I'm happy to share that with those that might be interested. Our signals look like we're seeing some signs that some people can sustain. We're seeing some signs that our enhanced condition might be having some signals, but it's a little too early to tell. I also want to acknowledge we're testing 2 bundled multi-level strategies, so we can't really say what's driving the effectiveness. But if I had to put my money on it from what I'm hearing from partners, people seem to be getting a lot out of the facilitation. And we really aren't paying a lot in incentives. I think in our whole first cohort of over 50 folks, we paid out maybe $5,000. So it doesn't seem like the incentives are driving as much as we thought. It seems like that those ISF sessions where people are focusing on facilitation seems to be what's really driving the effect. As a concluding thought about this study, the true sign for me of a great project and a great team is when things have real world impact. And I'm so proud to share that in the state of California, they are about to roll out contingency management as a reimbursable service throughout the entire state. It will be a $58 million initiative under the Cali Aid product. And I'm an advisor to this rollout, and it looks like they're going to use our ATTC training strategy throughout the state. They have already made a plan to use didactic training, fidelity monitoring, and ongoing consultation. I will say that initially they were just going to do didactic training, and they actually looked to our data to really document the fact that didactic training is not enough, that we need to give people ongoing support. So it's really exciting to be part of this initiative. So this is where I planned to pause and just see if there were any questions or comments in the chat.
Sara, there is a question. It's from Brian Mustansky, and he asks, similar to the example that you have where in one of your studies you talked about compensating clinicians to complete logs, and when you're studying different implementation approaches and when researchers use incentives or certain tools to maybe improve the fidelity of the research, how do you differentiate that from what you'll need to sustain those interventions in practice? And how do you deal with that tension of, maybe overusing or maybe being too heavy-handed in the implementation strategies as a research team?
That's a great question. And Brian, I'm a huge fan of your work. So hi, it's nice to virtually meet you. This is something that Brian and I talked about a lot with our project officer when designing this study, because there's a lot of data that pay for performance works. But we were like, who's going to fund this? We know the opioid treatment programs won't. So we actually took that head on in the grant proposal, and we argued that we felt that if the implementation strategy was effective, that the ATTCs could take that on, that we could make the case that as part of the SAMHSA funding that's given to these large training entities, or really the SAMHSA block grants, that you could justify that that should be used as part of the rollout strategy. We don't think that those should be done by the opioid treatment programs. those settings are super under-resourced, so the idea that they would pay staff incentives is very unlikely, but we wanted to see if there was proof of concept to really argue for this at the state level as part of block grants. Any other questions?
Yeah, Laura Kelly asked, do you feel like the training and facilitation helps encourage change champions, providers who are enthusiastic about contingency management, who share the enthusiasm with their care workers and patients? Does MIMIC have a measure how the training improves, the organizational climate to be more positive towards contingency management?
So Laura is a long-term colleague and friend. Hi, Laura. So let me start with the easier question first. Yes, we have a measure of implementation climate, and I'm happy to share. We did not develop it, and I might say it wrong. I think it was by Shay and colleagues, but Brian can correct me in the chat if I'm incorrect, but it's a very pragmatic team. Brian Weiner was one of the senior authors on the development of that scale, a really pragmatic tool to assess implementation climate. ISF, we don't explicitly require each organization to name a change champion, but certainly I think that's something that happens and that we know is often a best practice with organizational change. And so we have found, just because of staff turnover being so high, that rather than name one person, we try to cultivate a small core team at each site that basically becomes like a team of change champions, if you will. All right, so I'm going to go into the next study. Thank you, Ron, so much for helping me field those questions. This one is going to be much faster, so don't worry about the time. We'll get through it. But basically, this one is a completely different study. It's a dissemination science study. This was actually my first ever grant that was awarded in 2012. So I talk about it with a special fondness in my heart. But basically, the rationale for this study was I wanted to address the unmet need gap. And I wanted specifically to address this massive unmet need that fewer than 10% of adolescents who meet criteria for substance use disorder receive any treatment at all, and that we're told that's because often they don't know how to get help or they don't think they need it. I want to acknowledge that what I'm about to share was really shaped immensely by a mentor and really idol of mine, Dr. Valerie Zeitamel. She's an international pioneer in the field of services marketing. And way back in 2009 or 10, I cold called her and just basically said, I'm a psychologist, I do health research, and I'm really inspired by your work marketing services. Because services and products are different. And I was really inspired by the work she was doing to market services that are intangible in nature. And I asked if she'd be co-mentor on my K-23 proposal, and she said yes. And the rest is history, that much of the work in this program was really influenced by her pioneering marketing research. And so what I'm sharing here is really a way that I've started to think about marketing, really influenced by Valerie, which is that there's push marketing and pull marketing. And these are common concepts also in implementation science. But basically, if we think of push marketing or a push strategy, and we have a treatment developer, in a typical paradigm, what we are doing as treatment developers is we are marketing out to an intermediary, which we could think of as a practitioner, a clinician, someone out in that is delivering an intervention in the healthcare system, and they are then offering that treatment to a customer or consumer. So basically, we are pushing demand from the developer to an intermediary and then out to a customer. In a pull strategy, we use a different paradigm, where instead of relying on an intermediary, we go directly to the end user. And you'll notice on this slide that it says consumer/customer, and that's because those concepts are different in marketing. A customer is the person that actually funds, seeks out, and makes decisions about a service, while a consumer is the person that consumes the service. And your decision whom to target really varies on your goal. If your goal is to get someone in the door, you would target the customer. If your goal is to retain someone, you would be targeting the consumer. And so as someone that worked with adolescents, it became very clear to me that we needed to be thinking about how to use a pull strategy with parents, because parents are the ones usually driving treatment decision-making. So this was a 3-phase protocol. We specified the protocol up front, and we're able to publish it in Addiction Science and Clinical Practice. And these were all phases informed by services marketing. Phase 1 was formative qualitative research with the target audience. Phase 2 was a larger scale survey looking at whether what we found held in a larger sample. And then phase 3 was a randomized trial comparing our user-informed marketing versus the standard at the time. In our qualitative research, we had a surprise finding. I had gone into this as a naive new researcher. It was my first grant. I thought that we were going to find that people really liked the concept of evidence-based practice and that what we needed to do was figure out how to market it. What I learned is people didn't like the concept of evidence-based practice. In fact, people were saying, what do you mean by evidence? Do you mean like CSI? Do you mean like law and order? Like, what are you talking about? And people really had a lot of concerns. I then went to the research. To be honest, I should have done it the other order. But again, this was my first grant over 10 years ago. And what I found was that this wasn't an anomaly, that this had been documented. There was evidence among general health consumers that people are skeptical about the concept of evidence-based care. I also found similar findings among mental health patients, that there's this resistance to the concept of evidence-based care because people think it sounds inflexible, they think it sounds cookie cutter, and they're very resistant to the entire approach. So we followed that up with a larger scale survey, and what we found was that there was education was a hugely strong and consistent predictor of caregiver perceptions, and we found a troubling finding that caregivers from racial and ethnic minority groups with lower income per capita and lower education, were more likely to define evidence-based practice incorrectly and have negative impressions of the concept. We then followed this up. We used a marketing framework called the marketing mix, where we looked at marketing mix dimensions and how that affected patient perspectives. And basically we found that patient preferences varied as a function of income per capita, education, and history of treatment. And then in our final phase, we did a randomized trial where we actually created materials based on everything we had learned in the qualitative research and survey, and we tested that versus the standard at the time, which was the American Psychological Association's website about evidence-based practice. What you see on the left is the infographic that we created. Literally every panel was informed by users, by their preferences of what we asked them specifically, what words do you like to describe evidence-based practice? We asked them, what would you want in a brief handout? What you see on the right is from the American Psychological Association. Troubling fact, if you do a readability analysis of what is available by multiple national organizations, the typical grade level is usually between 12 and 15. What is recommended for the US general population is between 6th and 8th grade level. So our infographic is at like a 6.5 grade level versus I believe what's on the right is like 12.5. And so our findings were published recently in American Psychologist. It was the lead first paper in a series on dissemination and implementation science. And basically what we found was good and bad. So we did not find a main effect of our condition on outcomes, but we found a really exciting interaction, which was something we had specified a priori that we'd look at, which we found that those parents of teens who had active substance use problems, so the teens that had the highest substance use problems, those parents, if they saw our infographic about substance use, had 3.7 times higher odds of requesting information about evidence-based practice than those that did not. We also found a really cool, unexpected finding that parents of teens who had legal problems were much more likely to be interested in information about evidence-based practice overall. And I think that comes back to that, like, does evidence-based practice mean CSI? Does that mean law and order? There's something about the word evidence that I think has special weight for parents that are involved in the legal system. And this showed for us that they were really hungry for accurate information. So what does this mean? I realize I did that pretty quickly. I just gave you a little bit of a sampling there, but basically our takeaways from this program of research was that marketing can affect information seeking behavior, but specificity matters. And this has been shown over and over again in studies of pharmacotherapy and drugs that we know if you market Prozac, it will raise demand for all antidepressants, but it will not raise demand for an ADHD medication. So specificity matters. We also found that parents of adolescents with legal problems responded positively to accurate information about evidence-based practice, regardless of what they saw. So that to me suggests that there's the potential for targeted dissemination strategies down the road. So now I'm going to just share a bunch of really quick samples. First is one of an ongoing project. I saw that my colleague Goodman Sabeko is here from South Africa. He's my MPI on this project, and also our amazing colleague Kira Di Clemente is here as well. So hi, Goodman and Kira. But we have an ongoing project called that is based in South Africa, and it came out of a service center. So you noticed before that I direct the ATTC Center, and much of our research has come out of the ATTC. This was similar. We had a SAMHSA and PEPFAR jointly funded center in South Africa that was meant to serve the addiction and HIV workforce. And what we were able to do was use that as a platform to apply for additional funding from NIAAA. And what's shown on this slide are just a variety of images. This is to show that there was an international network of centers and that what we decided to target in this study was really part of the 90-90-90 cascade targets of HIV, the fact that people really struggle with retention on HIV treatment, and that is believed to be driven in large part by high rates of alcohol use. We also did a national needs assessment. That's a theme that keeps coming up. Talk to your stakeholders. And we found that there was a strong desire for alcohol screening and drug screening training. So we are doing a cascade train the trainer model where we're really trying to build the capacity of lay counselors to deliver screening and brief intervention. And I'm just for the sake of time, I'm going to keep going. Another project that's active is an R37. My colleague, Sara is here today, and she's a co-I on this project. But basically an R37 is basically like an R01, but you can be funded for up to 10 years, which is really exciting and cool. And this was awarded about a year ago. And basically this study came out of an R34 that we had done previously, but this is a project I would identify as a dissemination science project, because our goal is to circumvent barriers at the practitioner level and go directly to patients by making treatment more accessible. And in this project, we use a technology program that has a computerized program. We have an app, and we also have some telehealth coaching sessions. Without going into too much detail, I just want to emphasize that this was really user-centered. We used principles of user-centered design to design the intervention. And we are now testing its effects in partnership with Rosecrafts, which is actually pretty close to you all in Northwestern. They're based in Rockville, Illinois. Here are just some pictures of our program and the app that we've designed. I'm also super excited to share that we have 2 center grants in progress with Northwestern's own amazing C. Hendricks Brown as a collaborator on both of these. One is a NIDA P50. Hendricks is PI, I believe, of our research and evaluation core, and I'm PI of the largest project. And then Hendricks and I are MPIs of a UTC project that literally was just submitted last night at 11:30 at night. And what you're seeing here are just some graphics. The one on the left is one I made. The one on the right is one made by a graphic designer. So don't judge the difference in quality. But basically the one on the left shows we're trying to argue that effective interventions exist across all the pillars of the Health and Human Services overdose prevention strategy. But what is lacking is that foundation of translation of evidence-based interventions into practice. And what you see on the right is our argument that when we have a standard efficacy to effectiveness paradigm, there's a big black box in the middle that we often don't unpack about the ingredients of interventions. And we are replicating a lot of those problems in implementation science. You often see people talk about, oh, there was this intervention that is evidence-based and I helped people to get it into the community via facilitation. But there's no description of what were the ingredients of that facilitation. Did you monitor fidelity of the facilitation? If someone wanted to replicate it, what would be the key elements? What did it cost? And so we are trying to advocate an advanced dissemination and implementation science paradigm where we really unpack that black box of implementation strategies. I'm going to now do a friendly, shameless plug. My colleague Kelly Scott is here also in the audience today. We wrote a paper with our colleague Ronnie Elway for a special issue about brief interventions on risky drinking, where it was basically a primer of if someone wants to lean into this space, what are some key principles that you can do? And so we try to break down just 5 guiding principles that we think can be helpful for doing work in this space. So let me look at the time. So I'm going to try in the next 3 to 5 minutes to just share some quick thoughts about future directions in dissemination and implementation science. And if you've ever attended a talk with me before, you know I really like to use GIFs. You might also have heard me rant that I always thought it was pronounced GIF, but my team and I had a raucous debate about this and we found out it's Jif, like the peanut butter, even though it's spelled GIF. So hopefully if you didn't know that, that's a fun fact you can take away with you today. All right, so I have 4 directions that I think are really important for the field of D&I that I'm excited to move my team into over the coming years. So the first, you've probably gotten a sense from today's talk that I really think that we neglect dissemination science. I think as a field, we're getting better and better at thinking about how to increase the supply of effective treatments into usual care settings, but we really need to be thinking with more intention about dissemination science. I just keep thinking about the vaccine rollout and the failure to really get around misinformation and really get people to demand the vaccines. And I think this is an area that's really ripe for future research. A second area that I think is really important is policy and financial levers. As someone that has this really exciting opportunity to be working with the state of California, it's been really clear that as we are trying to think about how to use policy levers, how to think about reimbursement, that we're kind of like flying by the seat of our pants in a lot of ways. There's not a lot of best practices documented about thinking about these levers. There are, of course, exceptions. My colleague Beth McGinty is doing some really cool work in financing in the addiction space. But this is an area that I think needs a lot more attention and that I hope to see the field go, and that certainly I'm interested in leaning into. And then a third area, I think the field of dissemination and implementation science really needs to be thinking more intentionally about promoting equity and anti-racism in all of our framework strategies and outcomes. I think especially when you look historically at some of our landmark frameworks, equity is not even included. That is changing. So there's a CFR 2.0 that has a much stronger focus on equity. There's been publications adjusting REAIM to include equity, just as some common examples. But this is an area where I think there's a lot of work to be done, to be thinking about not just implementing something, but implementing it equitably. And on the left is one of my favorite quotes. Years ago, my friends and I went to the Women's March in DC, and one of my friends had this quote on her sign. It's a really great quote about anti-racism. And then finally, something that is really near and dear to me as someone that directs a regional training center. So I consider myself an implementation practitioner as well as a scientist. We need more pragmatic frameworks, strategies, and tools. You know, as someone that I wear both my practitioner hat and my scientist hat, and sometimes with my practitioner hat, the tools that are available in the implementation science field aren't all that helpful to me. And I think that sometimes I hear people present and they'll talk about their pragmatic tool or their pragmatic questionnaire that's like 30 items. And I think we have to challenge ourselves to think about being pragmatic and being practical from the perspective of a stakeholder that really needed help yesterday, that they're drowning, that their productivity targets are off the charts, they have no time in their day. And so we need to be thinking about, you know, how do we help people pick implementation science strategies in a way that's easy, you know, that there's clear ways to do it. And I think we're making moves to make things accessible, but I would say we could really get to a level where things are a lot easier and more practical. And so, of course, there are so many people. It takes a village to do this work. So I want to thank all my collaborators, my active team, and my grad students. One of the coolest things about having a slide like this is when you see people move from the staff or grad student category to your collaborators. Actually, I have 4 collaborators listed that used to be grad students or fellows. And Kira, who's listed as a grad student effective May 1, will be promoted and will be moving over to the collaborators as well. So just want to thank all of them for being here. And how did we do? We have a little bit of time for questions.
We do. Thank you so much, Sarah. We'll dive right in. There's a few in the Q&A. The first is from Lisa Hirschhorn, who asked whether, I think with reference to an earlier graph where you showed sort of a delay in implementation and then some drop in gain with sustainment. I think the question is really, do you ever, or to what extent do you look at heterogeneity and try to predict maybe which settings need different types of strategies or more intensive facilitation to achieve implementation?
Oh, that's such a good question, Lisa. So that is something Brian and I have been actively talking about when thinking about our implementation research. And this is why, so we're right. It's hard for me to conclude all that much about MIMIC in terms of who needs more intense, because we were 7 months into our first cohort when COVID hit. And so a lot of the challenges, it was hard to tease apart. Is this specifically related to contingency management or some of the barriers to implementing, or is this because the program was shut down essentially, or they shifted to take homes and we're giving patients medication 28 days at a time. We are doing intensive qualitative interviews now, and I'm hesitant to answer your question until I've had a chance to analyze that data, because I'm a real believer in listening to the stakeholders, before trying to come up with conclusions. But it's something we haven't been doing historically, but I think is a great suggestion for our future research, of course, after we listen to what the sites are telling us about what they needed.
Pat Franklin asked a question about whether or to what extent you're measuring process measures of the consistency of use. And I think her question might relate to how to reinforce clinicians to basically implement things routinely in their practice. And so to what extent are you looking at, I guess, at a physician or clinician or practitioner level and measuring process of implementation and then trying to design your strategies to reinforce routine behavior?
Yeah, that's a great question. So we are measuring all of those things in detail. We'll be able at the provider level to look at things like consistency. We'll be able to look both within each patient and then across providers, but we haven't finished analyzing yet. So we haven't been able to analyze to adjust. I would say one of the things with Mimic, because there are so many programs, I barely had time to talk about this, but we created an electronic platform for people to share data. Working with community agencies, we actually had some agencies that still use paper. We had some agencies that have homegrown electronic medical record systems. So one of the hardest things was, how do we even get data from these agencies in a way that we can analyze them? And so that was a feat in itself, was coming up with a platform that we could get data. So all the things you're asking are things we're tracking, but we have not yet gotten to the step of analyzing it to inform our next steps. And I see that Lisa put a follow-up in the chat about doing work to wean down coaching, which is very cool, Lisa.
I have a question for you, Sara. It relates to a lot of the examples you gave. Really, I think of other presenters that came from the framework of I'm a behavioral economist or I'm a community and stakeholder engaged researcher, and they're using similar approaches that you are, but slightly different, not maybe implementation science frameworks. So I'm wondering, are you those things as well? Are you is the field of implementation science at risk of maybe defining itself too narrowly, or is it already encompassing all of those things? Because I think there are people that do those types of research activities regularly who maybe don't call themselves implementation scientists. And I really liked your examples of drawing from these other fields and applying them in implementation science examples. I wonder if you can comment on that.
Yeah, I think one of my favorite slides ever about this is from Enola Proctor. She came and gave a grand rounds at Brown a few years ago, where she basically had a slide called "A Big, Colorful, Inclusive Tent." And she had all these different bubbles. It was like health communication, health economists, like QI initiatives. And she was basically making the argument that when we talk about implementation science, it's a big umbrella term that really overlaps with all of those things. And so I think we do run the risk sometimes of acting like we're recreating things. I've had practitioners, especially in the ATTC space, some of the directors will say, it seems like implementation science is just making lists of things, or making taxonomies of things. And so I think we do run the risk of sometimes seeming like we're just starting over or redefining things people are already doing. But I think really, truly broadly, D&I research is just a very broad, inclusive tent that overlaps with a lot of what people are doing, because in a true, broadly speaking term, it's the study of strategies to bridge the gap. And many of things that people are doing, people are studying health economists, people that are doing health communication are doing D&I science. They're just specific elements of it.
Well, I want to thank you again, Sara. That takes us to the top of the hour, and a particular big thanks on presenting to us on this day, just I guess about 12 and a half hours after you submitted a large grant. Special thanks for that. Sorry we did that to you, but thank you so much again.
Yeah, thanks for having me. Thanks all for coming.